that's an excellent question. Over the last 2 decades, there's been multiple systemic therapies. So things like targeted therapies, immunotherapies, combination therapies that have been developed and become approved for the treatment of metastatic renal cell cancer. During this time, really the focus has been on systemic therapies and not as much on surgery or the integration of surgery. There were 2 randomized trials done at the turn of the century, or published at the turn of the century, that showed that there was an improvement in overall survival. And subsequently, most of the clinical trials were then designed to include patients who had had a prior nephrectomy. So the majority of patients in the large clinical trials with systemic therapy have had a prior nephrectomy. There's only really been a couple of clinical trials that have tried to study whether surgery it still has a large effect for some patients, and then the proper timing of surgery. The CARMENA clinical trial that you mentioned, where they looked at patients who had either immediate surgery and then systemic therapy, or systemic therapy alone. The trial, unfortunately, the way it's been interpreted, because it had a lot of patients that were poor risk, so patients that we probably would not have offered surgery to, they certainly would not have been considered optimal candidates for surgery. So a lot of people have looked at that trial and said, okay, well, that shows in the poor risk patients, those patients probably don't benefit from surgery, but we kind of knew that. Because the original clinical trials, they didn't have the same metrics to actually define risk, but there were a lot of patients with just one site of metastatic disease. A lot of the patients that did well had very good performance status, but it's difficult to compare studies historically in time. The SURTIME trial is another trial. Unfortunately, it failed to accrue. Both CARMENA and SURTIME didn't meet their target metrics. But we do believe that for a lot of patients, it does make sense to get upfront systemic therapy rather than surgery upfront, which should be reserved for more favorable patients or patients with symptomatic tumors. As we've gotten better with systemic therapies, we have become more and more stringent on our selection criteria. And that's probably because, in 2005, we didn't have many options. There was, the target therapies were very new, and a lot of patients didn't respond to them. And so we really thought, surgery was your best chance. And so maybe we selected patients during that era that wouldn't have been selected during the modern era. We chose 2005 because that's when it's roughly when targeted therapies became available in the United States for treatment. And then we finished in 2019, just because that's the year right before COVID. COVID impacted a whole lot of the way we do the treatment, so we didn't want to include that in our analysis. And then we broke it up into 3 5-year cohorts, roughly to correspond just for years. And then they had different numbers of patients, but the last 5 years would be really the era where immunotherapies or immuno-oncology agents became available, and they were not available prior to that. I think it's primarily patient selection. We haven't changed the technology of our surgery drastically, or the technology of our critical care drastically in the last 15 years. I think this is primarily selection, and you can see it in the different baseline demographics. Probably the thing that we have changed is we try to get patients out of the hospital a little bit earlier. In the more recent, you can see that they have a shorter length of stay. But I think it's really critical to look at the fact that the perioperative mortality in the earliest group was about 3%, and now it's about 1% in the most recent group. So we think that that's really important when we talk to patients in clinic, when you're trying to set expectations. This is the risk, it's about 1% risk of perioperative mortality, and maybe a 10% risk of major complications. But a lot of those complications are manageable, and patients, again, can go on to get systemic therapy in a pretty timely fashion.